So, Sunena, we will go live now. Let me start with introduction to the event. Good evening, everyone. I am Adipti Naik, and on the behalf of IntelliMed Healthcare Solutions, I invite you to a webinar on health economics and outcomes research, health technology assessment, the evolving role in Indian healthcare ecosystem. I also welcome you all on the behalf of our academic partners, IMPA, which is Indian Medical Pharmacologist Association, expert partners, Alpha MD, media partners, PharmaShot. Just to give you some insights, we have had an overwhelming response the moment we announced this webinar. And I can clearly say it was not just because of the topics, but also because of the subject matter experts who agreed to be on the panel. And we are truly humbled that you all have accepted and today are here to share your insights on topics related to health economics and outcomes research. So before we quickly get into with our speakers, let me give you a quick look into the topic. Health economics and outcome research, HEOR, is a growing field that provides important information for making healthcare coverage and access decisions. Health economics, it analyzes the economic aspect of health and healthcare with a focus on the cost and consequences of healthcare interventions. Outcomes research evaluates the effect of healthcare interventions on patient-related clinical, humanistic, and economic outcomes. With increasing access and utilization of healthcare, resources become more restricted and prioritization in healthcare becomes unavoidable. Health economics and outcomes research is a discipline that is used to complement traditional clinical development information to guide decision makers regarding patient access to specific drugs and services. HEOR has advanced considerably in methodology and in quantity over the past several decades. HEOR can provide data to help the healthcare payers determine if treatment works in the populations they serve and how much of the drug or treatment cost should be reimbursed by the healthcare system. As a key part of the request for comparative effectiveness evidence, the increased use of HEOR data can be expected in future decision-making processes. In addition, a great emphasis has recently been placed on positioning the patient at the center of healthcare decisions. Outcomes research plays an increasingly important role in this because it can provide data on specific populations and treatment combinations that are used. The pharmaceutical industry invests heavily in HEOR studies along with clinical trials and continues to collect clinical, humanistic, and economic real-world data throughout the life cycle of a therapy. So without keeping you any further from the insights that our experts will be sharing on this topic, let me introduce you to our first keynote address speaker for the evening, Professor K. Srinath Reddy. Sir, Professor K. Srinath Reddy is the President of Public Health Foundation of India, that is PHFI, and formerly headed the Department of Cardiology at All India Institute of Medical Sciences. Under his leadership, PHFI has established 5 Indian Institutes of Public Health in different regions of India. He is the first Indian to be elected to the National Academy of Medicine USA and awarded several prestigious international and national doctorates and fellowships. He holds an advisory position in several national and international bodies and recently published a book, Make Health in India, Reaching a Billion Plus. His contribution to public health has been recognized through several awards and honors. He has delivered more than 50 invited orations or lectures. Today, he is going to be talking to us on the need for affordable healthcare in India. I welcome Professor K. Srinath Reddy to please speak to us.
Good evening, and thank you very much for that kind introduction. It is a great pleasure to see that the whole idea of health economics is coming to the forefront. Public health and health have indeed become very important in this COVID-19 pandemic, but quite often the economic dimensions of health are only seen as something that happens to go wrong when we have a pandemic or a health emergency. But afterwards, the health system gets neglected and very scant attention is paid to the need for financing health and optimizing the investments in health. I hope from now on, we'll pay much greater attention to the health system needs, not only in terms of financing, but also in terms of appropriate investment for health interventions. And that's where health economics comes in as a very important discipline. Firstly, health itself has now very clearly come to the center stage. But we have long realized that health has both an intrinsic value as well as an instrumental value. The intrinsic value is often taken for granted, but it is well worth recounting that it involves a sense of well-being, the ability for self-care or functionality, also participate in family life, conjugal life, have a good marital relationship and children, and also a variety of social interactions with the people that we want to associate with. But the instrumental value of health is when health enables a person to gain education, then subsequently employment, income, social status, participate in extended social networks, perhaps even participate in competitive sports and in a variety of performing arts. So all of those are essentially enabled by the health of the person. Yet, many of these things are taken for granted until health goes wrong. Because health and economic development have not always been seen as critically interlinked entities. We thought that health is going to be a passive beneficiary, while investment in health is needed essentially to fulfill certain functions and address some needs. It was never seen as a contributor to economic growth, as indeed many of the other sectors of industrial growth were, or agriculture was. And this particular feeling that even healthcare is a cost that must be inevitably borne, but not necessarily linked to economic growth, but on the contrary, even viewed as a cost, was propagated by a number of influential economists. William Baumol was one of the most important economists in America, as well as influenced global thought in the second half of the 20th century and part of this century as well, indeed described investment in healthcare as a cost disease. He said, unlike other sectors of economic investment, increasing investments are actually not going to result in commensurate economic returns. And after some time, it becomes an overwhelming cost. And he called it a cost disease. And that was the kind of thinking that permeated economic thinking, and policymakers also started falling into that trap. But then things started changing in 1993 with the publication of the report on investing in health, which at that time the World Bank led with two leading economists. And then we also found that subsequently the WHO established a commission on macroeconomics of health. And that too, by the time it was published in 2001, considerably made a dent in the thinking, conventional thinking, and showed that investing in health was absolutely critical, even for economic growth. That there is a bidirectional relationship that exists between societal economic growth and health, and health also fosters and accelerates societal growth. And then we had the second commission on investing in health in 2013, which further made the point and even estimated that if you take a full income analysis, then you are actually going to be having for $1 investment in low-income countries, $9 of return, and in middle-income countries, for $1 of investment, you will have $20 of return. So the whole idea of investing in health as an important element of economic growth also started coming into picture. And this was this commission on investing in health was headed by Larry Summers and Dean Jameson, and the earlier one on WHO Commission on Macroeconomics and Health was headed by Jeff Sachs, all influential economists. And economists themselves started making the case that investing in health was absolutely important for economic development. Then policymakers started listening. And even the Millennium Development Goals and the Sustainable Development Goals have actually reflected the philosophy that unless health is also fostered, we are never going to have all-round development, and certainly economic development also will falter. It is also was pointed out by a UN commission headed by two former presidents, President Hollande of France and President Zuma of South Africa, who in 2016, in their commission report, in terms of linking health and employment, showed that health is a great job creator. Indeed, even as jobs were falling, employment was falling in other sectors like industry, agriculture, and service sectors because of increasing advent of technology, which was actually taking up jobs. On the other hand, health was one sector where there was going to be a lot of job creation, creating avenues for a lot of young people who are yearning to get into the labor market, and creating also great opportunities for women's employment. So health now has begun to be seen as an important element of promoting even economic development, and we certainly must also ensure that economic development also results in greater allocation of resources to health, so that we can ensure that the health system itself performs well and renders the kind of services that are required for everybody. And it is in that context, it may be useful for us to look at what is happening in terms of the Indian health system, and also in terms of our levels of investment in health, and what we can do in terms of bringing universal health coverage in a much stronger fashion in order to correct some of the aberrations that have come into our policy and poor health indicators. As we can be fairly proud that our COVID-19 pandemic is coming under good control in India, we also must recognize that there are several health indicators of concern. If you look at infant mortality, in terms of our own neighbors, India's infant mortality is about 30 per 1,000 live births now. In Sri Lanka, it is 6. In China, it is 7.4. In Bangladesh, it's 25. If you look at life expectancy overall in India, it's 69.2 years. In Sri Lanka, it is 77. In Bangladesh, it's 72. In China, it is 76.5. India ranks 158 among 195 countries in expected human capital. And one of the reasons why we have not done well in health is because of our continued poor investment in health, particularly public financing. If you take the government health expenditure as a proportion of total health expenditure, India is 30%, Sri Lanka is 56%, China currently close to 60%, Brazil 46%, Japan 83.6%, Germany it is 77%, Thailand 77.8%, UK with NHS is 83%, USA, which is considered to be the poster child of private healthcare, the public financing of health as a proportion of total health expenditure in that country is 48.3%. And as a result, we have a very high level of out-of-pocket expenditure. In our case, it has been for a number of years close to 70, now it's close to 60, but still it's very high, because when you look at what the WHO as well as the World Bank say, it should be the out-of-pocket expenditure in a country that has achieved universal health coverage, the out-of-pocket expenditure should not exceed 15 to 20%. And therefore, we are far away from having that particular goal. But then we have indeed embraced the idea that we must bring about universal health coverage. And we have also subscribed to the Sustainable Development Goals and promised the world that we will actually deliver it by 2030. Even our national health policy of 2017 reinforces that commitment. So we have to discuss firstly, what is universal health coverage? Clearly, when we are talking about what is universal health coverage, the definition of WHO is very clear that universal health coverage is when all people receive the quality health and financial hardship. The emphasis is on all quality health services and without suffering financial hardship. And this indeed is also now target 3.8 of the Sustainable Development Goals. But then comes the question, can we really achieve all of this overnight? Can everybody get all the health services they need and with very little out-of-pocket expenditure? Clearly, this is a progressive effort. It cannot be done overnight. So that's why the whole concept of progressive realization of universal health coverage has come in. And in that, the WHO has come up with a cube in which there are 3 dimensions. One dimension is the population coverage, what proportion of population is covered. The other is service coverage, what is the service package? And then you get what is called the cost coverage, what proportion of the healthcare cost is actually covered by public financing, how much is the out-of-pocket expenditure reduced, what is the impact on reducing poverty related to healthcare expenditure. So that is so the key stakeholders will differ in society. The politicians are interested in population coverage because they would like to cover as many people as possible, partly because of equity considerations and partly because they'd like to please as many of the voters as possible, even if the service package is shallow. On the other hand, clinicians, doctors would very much want a very strong service package, whether it is cochlear implant or cardiac transplantation or renal dialysis, they want their patient to get the best. So the service package becomes very important for them. Whereas the people who are the economists and the civil servants managing the budgets are interested in poverty reduction, out-of-pocket expenditure being reduced, at the same time maintaining fiscal prudence so that the budget doesn't go bust. Now there's a dynamic tension between all 3 of these, but then at any given point in time, based on the available resources, we'll have to try and manage the tension to get the best possible results in terms of cost effectiveness as well as equity, because those are the 2 principal considerations that will come in apart from the burden of disease. We have to look at what are the interventions or what are the components of the service package that are going to be very cost effective, both among or a particular disease condition as well as across different health conditions. And their economists are only now not only looking at cost effectiveness analysis, but what's called extended cost effectiveness analysis, which means in cost effectiveness analysis, you ask how much health for the money. In extended cost effectiveness analysis, you ask that question, but you also add another question, how much of out-of-pocket expenditure can we reduce by including this in the service package? How much of healthcare related impoverishment can we reduce? How much of catastrophic health expenditure can we reduce? Financial hardship can we reduce? So therefore, that element also has started coming in. And therefore, that is where we start looking at multiple issues, including health technology assessment. And there again, the whole idea of health economics and economic evaluation becomes very critical indeed in choosing the right kind of interventions to get into the service package of universal health coverage. And of course, whenever additional resources are available, the package can get expanded, but we have to definitely see how we can actually utilize some of the knowledge here for constructing the package that gives the optimum results at that point in time. But then in terms of equity, that also matters. Now, equity is often seen as treating everybody equally. That is what we can call horizontal equity. But there are people who have already been deprived for a variety of reasons of essential services in very many dimensions, including the social determinants of health. And there have been huge gaps in the health status of people, whether it is tribal populations or the poor people or a variety of other conditions which actually create that health equity gaps. So in order to bridge those health equity gaps, we may have to give additional resources or additional attention or additional service components to certain groups of people. And that is where the concept of vertical equity comes in, where you're trying to bridge in the equity gaps. And therefore, you have to balance horizontal equity as well as vertical equity as you construct the universal health coverage package. And again, here, health economics plays a big role because, again, we would like to get the maximum benefit both in terms of optimizing our resources, which are limited always, and also ensuring not only we are getting the best in terms of cost effectiveness, extended cost effectiveness, but also providing the equity benefits as well for people who need it. And that is where I believe the health economics and health technology assessment become absolutely important as we advance towards our universal health coverage. Of course, we have had in India attempts to do this in the past. We have had the National Health Mission coming in, certainly bringing in more services to people and also looking at the equity dimension. We have also had the Rashtriya Swasthya Bima Yojana, but they were all incomplete packages. They did not look at all the healthcare needs of the population. They only focused on certain elements like maternal and child health services. They focused a little on some of the infectious diseases and some nutritional problems, but non-communicable diseases were left out. Mental health was left out. Many other elements were left out. Indeed, only 15% of the healthcare needs of the population were covered by the National Health Mission before it became much more of a comprehensive mission. Then even the Rashtriya Swasthya Bima Yojana had limited degree of cost coverage, only 30,000 rupees for a family, and that was inadequate anyway. And therefore, now we are looking at different dimensions of the Ayushman Bharat, in which we're looking at comprehensive primary health coverage with a much more extended package of services planned. We're also looking at much larger amount of cost coverage for hospitalization, up to 5 lakhs per family. But even there, we are seeing the missing middle, because what happens to the people who are just above that 40% population level? So there are people who are going to be vulnerable to healthcare costs and could be pushed into poverty. We know that despite the National Health Mission and the Rashtriya Swasthya Bima Yojana, 7% of the population continue to face the threat of poverty each year because of unaffordable healthcare costs. So while access to services increased, the financial hardship did not decrease. So now we are looking at a different and augmented package of Ayushman Bharat. But even then, there will be vulnerable sections in the population whom we need to cover, and perhaps even allow some of them to buy into the Pradhan Mantri Jan Arogya Yojana with income graded premium payment. So we'll have to look at the missing middle also as an important element as to try and provide the coverage. But everywhere, as we move in this direction, we will have to get the value for our money. As it's been very clearly said, that we do need more money for health. We cannot really do anything without investing in a larger health workforce. We cannot do without adequate amount of drugs being available at every level of care in an affordable manner. Diagnostics are important. We do need better health management information systems. We certainly need many of the things to do, infrastructure and service coverage. All of them are going to be important, improving our primary healthcare infrastructure, district hospitals, medical college hospitals. So all levels of care, and how do we integrate these levels of care? How do we actually do the payment package? Is it fee for service or what's called the capitation or the bundle payment type of system? All of these are going to be important debatable issues. But everywhere we come back to health economics, because we do need more money for health, but also more health for the money. That means for every rupee invested, we must get better returns. And that is where health economics and health technology assessment comes in very clearly, that we must have definitely greater amount of public financing for health, and overall country's expenditure on health must go up, but it must yield the best returns in terms of health and well-being. Therefore, we need allocative efficiencies, we need utilization efficiencies, and therefore we do require a much better understanding of health economics and health technology assessment. And that is what we need to bring in full strength to our universal health coverage program if we are going to make progress in our health system. No longer should we be falling behind our neighbors in vital health indicators, because India, with its economic growth pattern, should actually be doing much better in health. And if we apply our knowledge properly, I'm sure we will. Thank you very much.
Thank you very much, Professor K. Srinath Reddy. Your speech was absolutely mind-boggling with its statistics with respect to health and healthcare. Your take on universal healthcare coverage program was so much comprehensive, and also you touched upon the comprehensive health package that needs to be worked upon. Thank you very much for your insights. They are absolutely valuable, and the way you speak shows how much efforts, energies, and enthusiasms you have put in towards this program. We will certainly hope and try to do as much as we can on our behalf. So next, I would like to address and introduce to us the special address that we are going to have by Dr. V.M. Katoch. Dr. Katoch is currently the Secretary, Department of Health Research, in the Government of India and Director General, Indian Council of Medical Research. Dr. Katoch has had an illustrious career, both as a doctor as well as a medical researcher. He contributed to the development of molecular methods for the rapid diagnosis of TB and leprosy. He has published more than 250 research papers in journals of international repute. Dr. V.M. Katoch is a recipient of many prestigious awards. Dr. Katoch is a fellow of all prestigious academies of the country. Today, he is going to be talking to us on the role of economic evidence in India for affordable healthcare. I welcome Dr. Katoch to address the gathering.
Thank you, Deepti. In fact, you got my introduction, which is very old. I retired as a secretary and the DG 6 years back. So somebody gave you a wrong slide. Anyway, there's no problem. That doesn't make a difference. Because that's by past and not a bad past. But anyway.
My apologies, sir.
Yes. Anyway, that's the problem with your organizing system, not with you. See but I mean, ignore that. Yes. See, what I'm telling you, the topic, which Dr. Srinath Reddy has already given the real spirit to the issue. Why you need, what is the really here after talking about the issues, the problems, and the expectations of a healthy nation, healthy people, and you need the investment, but if you have a money, even what you do with that, and how you use the money if it's available in limited quantity. See that's where in a neutral way of looking, in scientific way of looking at the issue arises. Now, you as industrialists, the people who are today looking at the key organizers, you belong to the industry, you were part of the industry, or you will be part of industry again. You really want to look at an orderly system. Why are you interested in the whole game? Because you as an industrialist, either the past or present or future, you are interested in what role we play. Not as a philanthropic alone all the time, but even if you want to invest, where to invest? And will you get a fair deal in that? See, the systems which were in operation earlier, I don't think they were a dishonest system. I'm not casting a motives on anybody. But the way of management was like a doctor. Dr. Reddy gave example that if the doctors take a decision, they will be looking at the best, but not necessarily looking at the people, which people like Dr. Srinath Reddy try to look at. He looks at the people, he looks at the communities, he looks at the periphery. He doesn't look at what is the best actually. He looks what is the best what for the maximum people at the same time, because that should, they have a right to be healthy. And that has been, if you look at that is the approach, which should be the approach in a democracy. And that becomes the approach when, you know, the health moves to the center stage. Now, health has moved to the center stage, unfortunately, after long years. It started off very well in the first 10 years after independence, but then gradually health was not on the agenda because the people didn't ask for it. It's not the part of the politics actually. I always very clearly tell politicians are not responsible for this. That's what the people of India asked for it, because they were more interested in a building, they were more interested in an airport, they're more interested in a big road. So the naturally what the people demand, the diversion will be to that extent only. But health has returned to the center stage slowly, and people like Dr. Srinath Reddy, who have been constantly advocating, looking at the statistics, microanalysis. They made a huge impact on the whole show. See, for me, when I got interested into the subject which you are talking today, actually, I learned on the job, because 2008 I moved to Delhi, and 9-10 we were started preparing on the next 5-year plan, which 11th we submitted also. By looking at that issue, and around the same time I was invited to a WHO-sponsored program in IIT Chennai. They had a program there training for the health technology assessment. Then the same question was coming, technologies, then which technologies? How to promote which brand of technologies so that they reach to the maximum people? And Dr. Srinath Reddy at that time was working on this universal health coverage, his document. We were almost presenting to the parliament or the committee of the parliamentary committees of the MPs around the same time. And so his presentations, my own perceptions, looking at this, when I was being invited to a few places, then I thought, then I studied these systems, the health technology assessment movement across the world. It is nothing new actually. It is almost now it is something started in the 80s, 90s actually. 80s it started in 90s. It has already picked up, but it did well in few countries, but it flopped in other countries. There also the people wanted something, whether the insurance sector was interested, or is it like in some major power player, I won't name that country, but the industry also wants to push the drugs which are very new, even if it's a good or bad drug, they don't care on that because the industry wants to make money out of it. They have invested. But the other countries where the people want to do a orderly system, that means the decision whether it is which treatment regimen, which appliance, if it is to be funded by public health system or to be funded by insurance, there should be a method. So, and that led to the movements actually by which the nice type of good models emerged in UK, very high-tech type of good systems emerged in Thailand, and there are some other good examples too at the same time. Now, that all, I think that's the time we started looking into a depth actually. And I discovered around the same time, 11, 12 actually, that when we put in our document for the government, it was we wanted to create a health technology assessment board. That name I had given, just a staff of 5 or 6 people, so that a movement starts actually somewhere. But I knew that some governments have already working with the NICE, they are working with the high tech, like in Kerala, in some other places also. So there were only the individual interest of few politicians or good enlightened bureaucrats, but not as a system actually. Specialists, very important dignitaries, important qualified doctors, they will sit on the boards, they will decide which instrument to be purchased. But when purchasing that instrument, they are taking decision of something that is most modern, is the best. But by using that best, how many people will be benefited? I was facing same trouble in some institutions under my ICMR and the Department of Health Research also. There that somebody will go for equipment which is 3 times costly, but he won't have the 3 times betterment of the excess of the diagnosis of the improvement in the services. So that's the main point, that the investment, whatever money, it was less money anyway, But more money, which was, even when the money was spent, it was spent on the judgment of the people who could not decide. They had a perception. I don't say they were dishonest, all of them. Some of them might be dishonest also, but most of them were not dishonest. They thought something they are doing for the betterment. But in fact, this is their perception. It is no calculation actually. So it is their arbitrary judgment. And then the companies will chase on them only. So it is a crony type of a capitalism, which is where the people are pushing something for a big money because you make big money out of it. And at the same time, so the industry is also part of the same nexus because there is no choice for them, because there is no system by which you will purchase something which will benefit the masses. It's not the industry's problem. So today when, but 10 years, slowly and slowly, we gave a commitment to the parliament. The board slightly, some system came in the Department of Health Research. Now it has become a vibrant system. The WHO-led movement had led to the training of so many people. So many players contributed. So today India has a fairly a good amount of people who can perform health technology assessment. And they have done for maybe more than 100 conditions at the same time. And many governments are making use of that also. But it has not become a part of a routine. It is not become a mandatory the way it has become mandatory in UK, actually, for example. There's a nice recommendation, even on a new drug to be introduced, is mandatory, actually. And their judgment they deliver like in 54 days, on 74 days, or 60 days. It is a system working there. And then the industry also trusts it. Industry knows where to invest, actually. So today, the need is, for example, where we are reached today, India has progressed quite well on the front of health technology assessment. That is, systems they're coming in place, but they have not become universalized. Now that pressure will certainly come from the thought leaders like when the people like Dr. Srinath Reddy, they keep on talking on the same subject. Then people listen because he talks with the conviction and the data. There are other players, who support the same type of psychology. More of our political figures also thinking that perspective. More bureaucrats are thinking from that perspective. But it should become an institutionalized system so that we must invest more, but that's a very different question altogether. I'm not debating that. You need more money. But even if you have money, how you use it actually, so that the goals of the people get the best care everywhere around. It is not the few good institutions created in the capital of a one state or one place actually. That means it is all a universal health coverage, which Dr. Srinath has been as a philosophy talking about, and that's accepted by the government. And how to do that, whether the insurance use that or the money is spent by the government directly or is done by somebody else, that investment into the technology, investment into the drugs is based on real improvements, outcomes. And those improvements are in the health indicators, whether it's for the promotive side, health indicators for the preventive side, health indicators when it's the curative side, and the healthier life afterwards. Because those healthier people will lead to a better economy, they lead to a better productivity, they lead to for a better society. So I think from that perspective, the health technology assessment system has been taking shape in India. It is doing quite well, I'm telling you. Even after I left the office, my successors did even quite very, very well actually. They have tried to contribute to the maximum, but then it should become a part of every government system. Whether the state decides, a hospital decides, a district decides, or the federal government decides. It should become that this is the statutory way of working. They can keep on improving how to make it better and better, but it should become a statutory. But then another issue rises, which is the people who deal with the health economics. This again, the health economics is not a very simple 2 and 2, 4 game actually. As Dr. Reddy's, if you listen to his talk very carefully, this has so many social complexities. There's so many other issues. So the health economists, number one, they are a very, very few number, very small number. And this kind of a specialist we need more and more and more. So they are able to analyze the things actually. They are able to then be a part of a decision making, because if they have an analytical mind, they write on that, they will be able to do it. So far, it has remained more to the urban elite type of thinking, actually. It has not been guiding everybody. It has not got the imagination of the people who are teaching economics. It has not got the imagination of the people who really will develop these kind of local models. So until unless a lot of people are trained in that, you need that it will be a deficit for a while. But it can be done. For the health technology assessment side, yes, substantial people have been trained. Only thing they are to be used in an organized manner. That will give a fair deal to the people for whom we are working. That will give a very fair deal to the people who are collecting money and spending money. I'd say the government mainly. Okay. It will give a very fair deal to the industry also, whether it is a producer of vaccines or a drug or a appliance device, whatever. Because then you know that if I produce something for where I stand, how I will be judged, and will I make it? Will let me? It will be a fair deal by which I can produce something. I'll get it will be used by people, and I'll make money also at the same time because that's my job. That's my goal. So ultimately, in a healthy people, healthy industry, I think that's something can come by a very fast growth of the both the health economics as a subject, but mainly the health technology assessment as a system, which is implemented by everybody honestly, and so that it gives a fair play to everybody and to the growth of the country. And I think that's because India's growth actually means a lot to the world also, because we are a huge country. So I think ultimately, and as we are intellectually very strong country, we have to be on the track. We were not on the track as far as the health was concerned for long years. But as I again said, this was people's choice. They were more fascinated by fashionable things. They were not. I mean, I have my own memories. That's which I don't come because as a former techno bureaucrat, I can't share those memories. But it was not on the political agenda because the people were not asking for it. But now people are talking for it, and I think this has moved to the central agenda. But the thought leaders like Dr. Srinath Reddy, they have contributed immensely in terms of flagging the real issues, keep on talking with the data, commitment, feelings, sentiments, everything. And he has created a system by which a huge number of people have been trained. And there are other players also who have contributed to the similar movement. So that's certainly, I think today we are in a better shape. And hopefully we will move much faster now. And more such deliberations will be there by which we will create more people who can talk similar language and persuade. They are honest people on every level. They are honest politicians also. They are honest bureaucrats also, honest technocrats, and honest industry people also. Everybody. So ultimately, if we push for a system which is not arbitrary, then we succeed. I think that's the health technology assessment based on a sound health economics. I think fulfills that, creates that instrument, a vibrant instrument, by which there is a fair play and people get a good deal. Of course, the industry is a part of it, certainly. Best wishes, Jai Hind.
Dr. Katoch, I have to say you had a very positive tone to your discussion, though you did admit that there is a dearth of specialists in health economics, that the economists should look at it and people from the grassroots level with a fair understanding. But there was so much positivity in your note where the emphasis on outcomes for better society. And you also said that we are on the right track. Thank you very much. You have been yourself largely into action. So your speech was very motivating. I truly thank you for all your kind words. We now go on to our next guest speaker. Good morning, sir, Dr. Rajesh Balkrishnan, who is joining us. He is the professor of Public Health Services, University of Virginia School of Medicine, clinical professor, University of Virginia School of Nursing. Dr. Balkrishnan is a social epidemiologist whose research program focuses on medical care access, especially focused on long-term pharmacological treatment of medical conditions. Dr. Balkrishnan is a part of a research group that is exploring issues related to oncology care in rural Appalachia. In addition, he has served as key co-investigator on large national studies such as the United States of Renal Data System. At the University of Virginia, Dr. Balkrishnan is a member of the Cancer Population Health Sciences program at the UVA Cancer Center and clinical professor in the School of Nursing. He teaches 2 courses in health policy in the UVA MPH program and coordinates the public health grand rounds. Today, we have the privilege of having him with us, and he is going to be talking about the real world evaluations of the effectiveness of medical care with its relevance in the current scenario. Welcome, Dr. Rajesh Balakrishnan.
Thank you, Dipti. I think I had a presentation. Can you pull up the presentation, please?
Yeah, sure.
Thank you. Greetings to everyone from the United States. Ordinarily, I travel quite a bit to India, and I would be sort of speaking to probably all of you at a hall in Mumbai or somewhere. But I'm kind of doing this from the US today, and I wanted to take the time to acknowledge the 2 former speakers, Dr. Reddy and Dr. Katoch. They raised some very important issues, which I will kind of delve into a little bit further. They sort of talked about sort of issues with both efficiencies within the healthcare system, as well as sort of equity issues within the healthcare system as we potentially consider moving India towards increased healthcare coverage for individuals, and um, how increasingly people are sort of forced to face the heavy economic burden of healthcare if there isn't some type of coverage at the federal government level. I think this COVID epidemic has, amongst one of the few good things it's done is it's put health firmly in the center of people's minds. Ordinarily, it was not that way in countries in India, but right now, I think, given the impact this epidemic has had, people are really beginning to focus on health. And of course, there's no point, and we have a perfected medicine and medical care from an art to a science, but people are not going to get access to it until and unless it's affordable, it's available to everyone, and most importantly, whether it works. So in today's talk, that's what I'm kind of going to do is I'm going to give you one example of the line of research that I'm doing related to looking at sort of how effective medicines are. And trying to understand what works and what does not work in a real world. As many of you know, medicines are brought into the market by kind of doing some clinical trials, which often don't last very long. One of the criticisms, a couple of days back, I got the first dose of the COVID vaccine. And one of the criticisms that has been leveled against the vaccine is that it has been rushed into the market without proper testing. Sort of given a sort of emergency authorization type of use. So again, it's a chance that we take because there's really nothing else that we have. So when I talked to Anish about this presentation, he said that it would be useful to have a few slides. So I put together a slide presentation, which I'm going to walk through over here in just a bit. But essentially what it does, it focuses on this concept of real world effectiveness of medications. And so I'm going to head to the presentation right now. And so I'm going to just ask Dipti to forward the slides as we go through the slides. All right. So yes, so I guess, all right. So do we have the, I think we do have, yes, we do have the presentation over here. So by means of introduction, I am a professor in the Department of Public Health Sciences at the University of Virginia School of Medicine. I have been here at UVA for 6 years. Prior to that, I was at the University of Michigan. That's where I had quite a bit of a chance to interact with Dr. Reddy and his work at PHFI. In fact, I've been to the PHFI campus. So I think some great work is sort of being done over there. And I'm glad that I can speak to all of you. Next slide, please. So I kind of have to disclose my conflicts of interest. So I am a consultant for Merck and Company over here, but what I'm going to talk today in my presentation has got nothing to do with any of the products. I will not be pushing any of the products of Merck and Company. Next slide, please. So this is sort of the model which I have developed based on my research of the last 20 years. I have been looking at this issue of how people get access to medicines. I've been primarily working in the US setting, and I have been looking at sort of systems with factors within the US healthcare system that allow people to access different types of medicines and how they sort of use them. So I've been studying especially the behaviors of patients who have chronic long-term medical conditions that require constant treatment with medicines. So I kind of started my career with asthma and then sort of moved on to diabetes, and now I'm sort of predominantly work in sort of the cancer and kidney disease space. But again, basically, this whole issue of access to care becomes really, really important. I think this is now an issue in India also. People are getting sticker shocks of the cost of many medications which are under patent and have to be imported. And so again, getting access to those type of medicines are really, really difficult. Of course, the good news is that a large amount of essential medicines in India are controlled, price controlled. So people don't pay a lot of money out of their pocket to get access to those medicines. But basically, this whole issue of access to these medicines not only affects the use of the medicine by the patient, but also how doctors prescribe medications for patients, as well as some of the other types of care which patients get. And ultimately, all these factors go into influencing a patient's healthcare outcomes for the better or worse. Next slide, please. So effectiveness is something that I have been working on. Effectiveness of medicines is something that I've been working on for the past 25 years. It is, in fact, the degree to which improvements are actually attained. So there's one thing when you enroll patients in a clinical trial and give them the medicine and monitor them. It's another thing when the patient takes the medicine on a day-to-day basis and then has to deal with all the real-world issues, real-world tension, stressors, so on and so forth. So what we see in a clinical trial is what we call as efficacy, which is basically the benefits under ideal conditions. But effectiveness is sort of the benefits of the medicine under real world conditions with day-to-day life issues, with cost issues, with issues of health insurance, so on and so forth. So basically, effectiveness focuses on those benefits which we actually see, which is produced in the population. So this is what Dr. Srinath Reddy was referring to, and what his work and my work has been, which is sort of looking at the effects of this on large population. A doctor treats a single patient, whereas we public health scientists look at the impact of different types of medical care, medical technology, and medical services on a large group of people, and sometimes even countries and societies, and see how it sort of makes a difference. Next slide, please. So this is like, about 15, 20 years ago, people started kind of putting together conceptual frameworks around health. So basically, why this is important, because if we improve health in a large population, we can develop healthcare policies that benefit a lot of people. And also we can change things for the better to influence a person's life course for the better. So again, this is the thing. If we kind of, for example, we find that this COVID vaccine works, we know that we will ensure that the COVID vaccine is available to everybody who needs it, probably, and then also ensure that people across the world, across the country, get the COVID vaccine, so that over a lifetime they stop spreading the virus. They are immune to the virus, and then they can in turn be healthy. So all these things are pretty interconnected. This is sort of the population perspective of looking at sort of the effectiveness of a medical technology. Next slide, please. So I have done some work in this area, and this is the 3 E's as we talk about them. One is obviously whether healthcare is effective. Secondly, as Dr. Srinath Reddy said, of course, there's no point in having healthcare unless we sort of pay for it, are able to pay for it. That's where the efficiency comes, because we are increasingly constrained for resources as healthcare systems, as healthcare payers, as individuals. And finally, there's no point in creating all these technologies unless we can give them to people who actually need them the most. And a situation like COVID really has let us know that it's not just the health of ourselves, but we also have to be concerned about health of people around us. So again, making sure everybody who needs healthcare gets it has sort of become really important. That's the third E, which is equity. So most of my work has been summarized in this book called Evaluating the Healthcare System, which is now in its 4th edition. So I worked on it with a group of authors, and this is what I consider sort of one of the more significant products of my lifetime work. So next slide, please. So this is how we can essentially do, we are supposed to make health policy. Of course, oftentimes this rule is not followed, and politics and other drivers shape health policy. As we have seen currently, and I'll be the first one to say, we are suffering in the United States right now because of poor healthcare policy, which was made not based on the evidence, but based on the politics. Hopefully things will change with a new government. We are welcoming a new government which is more focused on science and the evidence provided by science. As they say, we have to sometimes go through periods of darkness to come to light. Hopefully things will improve for the better. But right now, our country is in a very, very bad shape because of the COVID virus. And the main reason for this is because the main agency in our country which sort of deals with the virus or infectious disease outbreaks, the Center for Disease Control, has basically been disempowered by our federal government to really do anything. And because of that, testing has been slow. Because of that, the availability of vaccines is really, really slow. So right now we are in a bad shape. We also are unable to implement, there have been no policies implemented which have been able to effectively restrict people's movements so as to control the virus. So again, this is to sort of tell you, we kind of have these 3 E's, as you can see on the right-hand side. The 3 E's are what actually need to shape healthcare policy: define which populations are at risk, then determine access and processes by which people get these medicines, and eventually ensuring that people have access to different types of healthcare is going to ensure the health and well-being of the population, which in turn is going to prevent major catastrophes like this, what we've been dealing with, the COVID outbreak. This is something that people like myself have been advocating for the past 25 odd years, but I guess I'm hoping that at least with this type of a shock that we have had with the COVID virus, people start paying attention to how we sort of need to actually develop health policies and health systems to benefit a large group of people and benefit our societies and countries. Next slide, please. So what I'm going to do next in the next few slides, I'll just show you, I kind of started this journey over 25 years ago, and this was the first paper I published. This was over 22 years ago. And this was my master's thesis at the University of North Carolina. Nowadays, everybody knows that, if you have a patient who has moderate to severe asthma, not only do they need a short-acting control medication, but they also need to be put on they need to be put on a long-term controller medication as well. In the mid-90s, that was not known. So mine was amongst the first studies that came out, which showed that in addition to those patients who had the short-term inhalers with them, if we gave patients the maintenance inhaler also with the corticosteroid, we were able to prevent patients from having asthmatic attacks and ending up in the hospitalizations. And now obviously it's everybody says, yes, you have asthma, okay, you need a controller corticosteroid medication as well. But 25 years ago it was not known then. So this is an example of where I've seen my research actually now translate into medical care policy. Now everybody is like knows about it, but 25 years ago it was something new. Next slide, please. The other research of mine, which has significantly shaped the health policy in this country, is we have as Dr. Reddy mentioned, almost 48%, 45% of our country has some type of federal insurance. This includes the low income, the disabled, and the elderly. The other groups have to depend on commercial or private insurance for their health care. But the elderly have insurance through the government. And studies like this, which I was involved in, which showed that patients who were taking their type 2 diabetes, older adults who are taking, so the Medicare program is primarily for older adults aged 65 years and older. So I was able to do a study where I was able to show that patients aged 65 years and older who are taking their type 2 diabetes medications like metformin regularly had lower amount of hospitalizations and healthcare use, which then sort of basically said, gave the idea for Medicare that we need to have a prescription drug plan as well, because prior to the 2008, prescription drug coverage was not offered by this program. But studies like this were able to show them that there is a value in covering medicines as well, because if you cover medicines and people take their medicines, we can avoid these more expensive hospitalizations that cost us far, far more than the cost of these medicines which are available generically. So that's another example of my research which has shaped policy. Next slide, please. This one I'll go through pretty quickly, but one of the things that has been is like, some of the medicines are very, very expensive, new medicines. And so insurers have been reluctant to adopt these medicines and often require doctors to go through a lot of loopholes, like basically applying for prior authorization of these medicines to make sure that they are not being abused in any way. So this was an issue with some of the medicines for insomnia, some of the newer medicines that came out, and so I was able to do a study which determined that basically patients were using those medicines only for insomnia. They were not using it for any other reason. So there was no need to do all this restrictive paperwork and have all these policies to restrict access to medicine. So that's another example of a research which has shaped the way people are provide getting access to these medicines. Next slide, please. So next, I'm going to talk very quickly about some of the work that I've been doing with adjuvant treatment, hormone therapy in breast cancer survivors. And I will kind of show you how we sort of determine sort of the real world effectiveness of the medicines. And of course, please don't worry if you don't understand the technicalities of all these presentations. The point I want to make is that how we sort of how we go about actually studying how medicines work for different populations, and how we do a series of studies that that show that. So the next slide, please. So, my recent work has focused in breast cancer. Breast cancer is a very, very big issue here, especially in the US. It's now fairly common in India also. My mother underwent successful treatment for early stage breast cancer just a few months ago in Mumbai. So it is becoming very, very common. It is in the US. It's the second most common cancer, second most common cause of cancer death. And basically, as of currently, there are over 100,000 women in the US who are dying each year because of breast cancer. So this is pretty common these days. As women are living longer, many of them are faced with this prospect of breast cancer, especially in the later years of their lives. Next slide, please. So basically, after a woman is successfully initially treated for breast cancer, either through surgery or through radiation or chemotherapy, what is done is drugs are used called adjuvant treatments, which are given to women. In the case of my mother, for example, there was no radiation performed. There was only a lumpectomy, a preventive lumpectomy, which was done, and the tumorous tissue was removed, and then she was put on this adjuvant hormone treatment. And so basically, without going into details about the hormone treatment, there have been several studies which have shown that long-term use of hormone treatment over a period of 5 to 10 years post initial treatment of breast cancer is not only associated with the tumor not recurring again, but also associated with general improvements in life and life quality in women. But the problem with some of these treatments, obviously, is that there is the use of these treatments is not very good. Many times women start these treatments and stop taking them. There are some side effects of these medicines that I will talk about in just a bit, which are truly an issue for women to take this medicine daily. It's fairly easy. It's one pill a day, which is taken for 5 to 10 years. But again, it's not particularly cheap. I think it's about 100 rupees a tablet, so which by Indian standards I think is still quite expensive. But what we find in the US is that poor women, women who are in and believe it or not, even in the US, we have significant pockets of poverty. We do find that outcomes of use of these treatments vary amongst different types of women by their socioeconomic status and the type of insurance they have, and so on and so forth. So there are a lot of issues with equity in the use of these medicines. Next slide, please. So next slide, please. Next slide, please. All right, great, thank you. So this area of the US is called the Appalachia region. This is where I work. As you can see, it encompasses a part of my state also, which is Virginia, but it goes a little bit further down there. This is an area which is bounded by the Appalachian Mountains. This used to be so I'm getting a thing to basically end my presentation pretty soon. So I have only like 10 minutes to finish it up. So I'm going to try to be brief over here. But this is an area where there is a lot of poverty and stuff like that. So next slide, please. Next slide. So basically, as you can see, the national trends show that the outcomes for breast cancer are much poorer in this part of the country compared to the rest of the country. Next slide, please. So basically, as I said, what we hope to study here is to look at what is happening with women taking these medicines in this area, and why is it that the outcomes of use of the women in this region are particularly worse compared to the rest of the United States. Next slide, please. So basically, as I said, this is adjuvant endocrine therapy. We need to take, women need to take this for a 5 to 10 year time period. And it is usually, it is taken orally. So it's not that much of a deal. And it's one, but there are some issues because, next slide, please. So what we did in the first study was we looked at women who initiated these treatments and followed them up, and we compared women who died compared to women who didn't die, and we actually compared the use of these medicines amongst women who used them properly versus women who did not use them properly. Next slide, please. So we were able to combine data from all these different states, and then we sort of looked at which type of women, how they were acting, whether there were any parts of the state where women were reporting different types of outcomes in these by use of these medicines. Next slide, please. So we basically found that only about 70% of the women used the medicine properly. So next slide, please. For a medicine like this, which determines life and death, we need to have almost 100% use of the medicines, whereas we found that it was much lower than that. And what we found was that a clear difference in women who were sort of using the, so again, by different classes of medicines, we did find a difference. Next slide, please. So we were able to show that women who were experiencing side effects and using pain medicines were less likely to use this medicine. Women who had problems having access to insurance had issues accessing these medicines. Next slide, please. But we were able to show clearly a difference in the survival of women who were using these medicines properly versus women who were not using. So women who were not using the medicine properly had higher mortality rates than women who were using the medicine properly. So clearly the medicine was working. Next slide, please. We were also able to show, so here, this is what we call as geospatial mapping. We were able to look at like parts of the state where the adherence was poor and part of the states where the adherence was good. So the redder areas indicate areas where the adherence was, or the use of medicine was good. And the bluer areas indicate where it was bad. So we've found that the redder areas you see are closer to like bigger cities like Pittsburgh and Philadelphia. The bluer areas are some of the more rural counties. Next slide, please. So we were able, next slide, I'm going to move this a little bit quickly here. So next slide, please. So we have some issues with our analysis. Next slide. But we were able to show that that there are disparities in the use of these treatments, and again there are different areas of the country where people are using these medicines differently, and access to these medicines are different. We also were able to show that a lot of women experience issues with pain, and the treatment of and using these pain medicines impacted the use of the hormone treatment. Next slide, please. So then we kind of began to look at this, and I'm going to skip over. Let's skip over the next 4-5 slides, please. So I kind of did a similar type of study. We were able to show again that certain, we'll skip, please. We were able to show that Black women had lower initiation of these treatments. Again, race is also a big issue in our country of like people getting access to medicines. That's another disparity that we have. Next slide, please. So again, this was a conclusion of the second study, and then I'll go to the final study here. Next slide, please. So then we kind of looked at this whole issue of pain medicine use and what was happening. And we sort of compared women who were using opioids. So one of the problems with these adjuvant hormone treatments is they have musculoskeletal side effects, and they have to be treated sometimes with short courses of opioids. Next slide, please. So we kind of looked at this a little bit more in detail, which women were using these opioids, which women were not using their opioids. And the next slide, please. So we were able to clearly show that women who were using opioids were more likely to discontinue their adjuvant hormone treatment. And so the phenomenon that we observed was this pain management was a big issue in rural areas. Women who were using these opioids oftentimes got addicted to opioids and stopped taking their hormone treatment. So as you can see, we are determining in the real world how and what factors sort of determine the effectiveness of a medicine in the real world. In this case, the effectiveness of adjuvant hormone therapy is complicated because of the opioid use for the management of the side effects of pain. Next slide, please. So this is basically next slide. Let's skip in the interest of time. So the overall, no, before that, just go one slide before, please. Yeah. So basically, we use a lot of health information technology and healthcare registries to look at the effectiveness of different types of medicines. We do what we call as comparative effectiveness studies to compare one group of treatment versus another. We also, with conditions like cancer, we focus on survivorship issues. We focus on disparities, which groups of patients get their medicines, which groups don't get the medicine. We look at quality of care and things like that. Next slide, please. So all this information will be available to you through the people organizing this webinar. Many of the publications are open access, so you can just access them and read them. This is information about me. If you want to get in touch with me to discuss any of my work, I am more than happy to. So thank you so much for your time.
Thank you so much. It was a very deep-rooted study that you've done, especially public health scientist and the effectiveness that you spoke about. Also, effectiveness, efficiency, and equity, the 3 E's that you mentioned. Now, we move on to our next session, which is a panel discussion. So I invite Mr. Vivek Padgaonkar, who is an independent healthcare consultant, former director OPPI, and formerly with GSK Sales and Marketing. Sir, can you please introduce the panel to us today?
Thank you so much, Dipti, and wonderful to participate in this panel. At the outset, let me express my sincere thanks to Intelmed for kindly allowing me to moderate this panel discussions on healthcare economics, studies for healthcare delivery in India, particularly industry perspective. The year 2020 will be remembered by all of us as a year of all-around catastrophic global disruption, with unprecedented impact on human lives, livelihood, economy, and ways of doing things, sparing virtually no one. The sole cause of which has been an event, COVID-19 global pandemic. The unprecedented event demands unprecedented measures, and that's what exactly we have seen in the outgoing year 2020. It will go in the history as an year that has seen in the globe, across the globe, all countries coming together against a common challenge, and a year that we have seen that all of us are coming together in solidarity to emerge stronger than ever before. Of course, India emerged as a provider of net health security and successfully shouldered its responsibility as pharmacy of the world. Moving away from year 2020, if one crystal gazes the incoming, yet another brand new year 2021, a lurking fear still haunts most of the people's mind. Will the all-around disruptions of 2020 be the new normal in 2021 with no further escalation of the current situation? India is often referred to as pharmacy of the world. This has been proven completely true during ongoing COVID-19 pandemic when India continued to produce and export critical life-saving medicines, PPE kits, ventilator, etc. to the rest of the world. The contribution of Indian pharmaceutical segment, as well as global put together, stepped in and stepped up their efforts in service to humanity. In fact, many experts predicted what's for India as we had to manage the largest population in country compared to many outside of China in the world. However, 10 months down the line, India stood out with one of the best country with minimal infection rate and the mortality rate. Now, India is ready to save the world with two locally developed vaccines. No one will have doubt to believe that the collaboration and the maturity demonstrated by Indian pharmaceutical sector, Indian pharma leaders, some of them are here, and the government and the bureaucrats together to define the new way the Indian pharmaceutical sector will be going ahead. The pandemic has brought about a lot of revelations for the pharmaceutical industry as well, celebrating the need to rethink the way in which pharma policies have been talked about. In today's complex world, the clinical and the commercial success depends upon three factors. I call it as DIE, D-I-E, data, insight, and evidence. Real world data, timely insight, and clinical evidence. In fact, the clinical evidence healthcare landscape in India has undergone a paradigm shift in recent years. Education and awareness continue to be the cornerstone of all management strategies. Generating epidemiological and health-related data need to be funded for development of better management strategies and optimum resource utilization. We have heard Dr. Srinath Reddy speaking about it. We have heard Dr. V.M. Katoch speaking about it. And we have seen some references of Dr. Balkrishnan as well. However, it is heartening to note that the Indian government has contributed significantly in the year 2020 by developing tech, data regulation, etc., particularly the human medicine-related data, human economy-related data, non-personal data, etc. Generating epidemiological and other health economics data need to be funded. I would like to reiterate what Dr. Srinath Reddy sir and Dr. Katoch sir has said. The investment in technology is a must. Yesterday's technology makes itself obsolete faster, and therefore the technology in healthcare need to have special status for the illness and wellness of Indian citizens, particularly at a time when future is becoming present reality in a very short span of time. With this quick preamble, let me profusely thank Dr. Vaidheesh Annaswamy, Mr. Omar Sherief, and Mr. Manoj Saxena and Dr. Anish Desai for taking time out and sharing their intelligence at this panel discussion. I think it is appropriate that none of them require an introduction. All of them have been, participating, contributing to the industry, but it will be important from the perspective of the speakers, for the audience. Let me quickly go through the introduction of the panel. Mr. Vaidheesh, Chief Executive Officer of North Star Access LLP, former MD GSK and VP South Asia, former MD Johnson & Johnson Medical India and VP Asia Pacific, former President OPPI, a leading industry pharma association in healthcare, a successful senior commercial leader from most admired Fortune 100 companies with more than 35 years of diverse experience in healthcare and FMCG industry, sound experience in building strong leadership for brands and franchises across various geographies and across various areas like healthcare, FMCG, etc. He's very passionate about adding value to the deserving and undeserved populace. Vaidheesh has won the Economics Time Award Most Promising Asian Leader of the year 2016. He has been conferred honorary membership of Laparoscopic Surgeons Association of India. He has earned many awards. Few of them are like Michael Porter's Award for Shared Value 2016 on behalf of GSK. Welcome, Vaidheesh, for this panel discussion. Let me now welcome Omar Sherief, Managing Director, Roche Diabetes Care. Thank you so much, Omar, for being with us. Omar has more than 20 years of experience in sales and marketing across various specialties across few geographies. Hardcore marketing professional and result-driven management executive with multifaceted experience in managing sales, marketing, general management, and of course, people management. He has very strong networking skills and ability to identify opportunities, ability to ensure that the opportunities are seized appropriately for the benefit of the group. Thank you so much, Omar, for joining us. Let me introduce Manoj Saxena. Manoj is a managing director of Bayer Zydus Pharma and CDS South Asia Bayer Pharma. Manoj assumed the position of managing director for Bayer Zydus Pharma Private Limited as well as cluster head pharmaceuticals for the diverse cluster of South Asia since April 2017. Manoj champions the cause of inclusion and diversity by sponsoring a community in Bayer Group. I think great cause, and is a member of Global Council of I&D, Innovation and Development. He is also one of the EC member of Organization of Pharmaceutical Producers of India, which represents research-based pharmaceutical industry in the country. With deep understanding of the healthcare industry in different geographical markets, Manoj has brought experience across functions and has taken senior roles in sales and marketing function, business analyst, general management. Before his current role in Bayer Zydus, Manoj was managing director of Malaysia, Singapore, Brunei, and country head for Bayer Pharmaceutical Vietnam. Thank you so much, Manoj, for taking time out. Welcome for this panel discussion. Dr. Anish Desai, Anish, welcome. He is the director of IntelliMed Healthcare Solutions and honorary professor in pharmaceutical medicine. Anish is a trained clinical pharmacologist and pharmaceutical physician with over 3 decades of experience in academia, research, healthcare industry, and deep understanding of healthcare systems, including pharmaceutical, nutraceutical, and medical device industry. IntelliMed Healthcare Solution is a healthcare startup launched by Anish with an intent to focus on strategic medical affairs for business growth, thereby focusing science into the business. Welcome, Anish. Thank you so much. I think let me try to quickly go through. I have a few questions, and of course, we'll try to have deliberations with the panelists. Vaidheesh, with your immense experience in public advocacy and also leading industry pharma association for a long time, would you like to share your views on the audience about the health economics in our country?
Okay, thanks, Vivek. Thanks, Dr. Anish. I think we had a wonderful session from the experts. I think it's pretty, all 3 speakers, we don't need to say more than what they said. Outstanding. So I want to say a big thanks to all of them for sharing their insights, and I'm quite privileged to be part of this group. So, I've spent since 1984, 83, 84, I've been in healthcare, where healthcare was primarily a public healthcare, where I remember having gone to KEM and attending a bypass surgery, where that's the only thing that was available, and Apollo Hospital was just coming up as a private hospital. I still remember when I was the regional manager South, Dr. Reddy requested for extra credit for sutures that we supplied, where at that time, private healthcare was considered as a sin. Making money out of healthcare was considered a sin, and bold by Dr. Pratap Reddy at that time, Apollo Hospital. So we have come a long way as a country looking at healthcare from a service, purely inspired service by the missionaries and hospitals, doctors who don't see this as something you need to make any revenue out of it. At the end of the day, as you all know, that 1947, when we gained independence, our average longevity, as Dr. Reddy also mentioned, today our longevity is gone up to almost we are in 70s average. That means there are people now living longer. So what we need to understand is, when you talk about the concept of health economics related to morbidity and mortality, right? Why do we take drugs, or why do we use technology? Everything is to increase your lifespan as much as possible. If you can live 120 years, then you need more technology. If you want to live 200 years, right? And similarly, you want to live without pain. better morbidity. So the question is, I think we need to get some awareness as a country, not because of anything else, just that we have been, our country, whether we like it or not, we don't recognize the fact we have increased our longevity. And thanks to the pharma industry, that has made a huge difference to making sure people don't die of small infections. People don't die of stomach ulcers, right? I remember people, some of our relatives have died of simple like pimple infections, right? Or a stomach infections. Today, nobody dies of that. Today, nobody dies of heart attacks. Means, and people do die, but there are people who have been saved, and now people are not dying of breast cancer. Now, what is happening is because new drugs have come in, new technologies have come in. So I want to quickly say a few sentences related to, see, the health technology, or when we talk about HENR, reimbursements and health economics, should be related to anything that's very innovative, that is different from the current standard of care, that shift the current standard of care from where it is today to where it should be tomorrow in two dimensions. One is morbidity and mortality. As long as it does that, do we need to pay for those technology or solutions? Now, that is a question that we need to get our arms around. As a country, we don't have the public, our healthcare system is not as integrated as a Western system, highly regulated system, where you have reimbursement body, payer, provider, physicians, policymakers, they're all integrated. In India, states are the healthcare, they run the healthcare delivery, and policymakers sit in Delhi, large policymakers, but at the end of the day, deliveries happen. And providers operate very independently, and physicians operate independently. So we do have a very unique healthcare system. So how do we deal with HENR? If the question that you asked is that relevance for India. We got to be careful about applying some of the method that we do in the United States or in UK. Because the way in which because I did spend time in Asia Pac, I was the head of the policies in with Johnson & Johnson. I spent time in Australia and in China. I know very well how it works. A brilliant mental health care system, the drugs that we provided at that point of time, it reduced the people with the mental health care system to get out of the hospital, come back home. Home care was done because of the drug. Now there's a costed out. And then they are willing to pay the price for it, okay? And similarly, laparoscopic surgery was open surgery. Open surgery was morbid. And it took a common man to spend 8 days or 10 days in a hospital, in a public hospital. Laparoscopic surgery gets a patient out of the hospital in 48 hours time, less morbidity, and he's able to stand on his feet. So that is health economics, right? Now, question which we need to do is that we need to start looking at health economics from an Indian perspective. And I'm just urging our Indian experts, PhDs and all those people to start looking at how do we start looking at the Indian healthcare system and apply health economics and make sure it becomes relevant, so that we don't talk about economics only, but we should also talk about what the economics does to the health of the population by way of morbidity and mortality through the innovation. And we should have the mindset to pay for the innovation. We can't be talking about the innovation is something that, like for example, still people are debating whether the vaccine that we have got, whether we should pay 240 rupees or whether we should pay 150 rupees, right? People have completely forgotten somebody has invested his money at risk, assuming the clinical trial has not gone off well. The investment made by Poonawalla would go down the drain. Now, who's going to pay for it? Correct? So somewhere down the line, we need to get the appreciation of innovation and start. If you don't respect this thought, what will happen is that you would not be able to encourage innovation. That is the reason why United States has been successful in creating more innovation, because there is a respect for innovation. I know there are some excesses that happen broadly. If you don't respect innovation, like what Poonawalla did for corona vaccine, I think we should celebrate. We should celebrate Bharat Biotech. We should celebrate nasal spray that they are trying to do, and we should say we are willing to pay for you. And that's where the Indians will be able to come up with innovation that's going to significantly increase the morbidity, improve the morbidity, increase mortality, and we all can live 100 years healthy. So that's my broad point of view related to health economics. I know there are various models that exist, but at this point of time, for the purpose of limited audience, I encourage young people to take up this as a science and work with experts. Hopefully, Dr. Reddy's organization embrace some of the youngsters to understand the whole health economics concept and put some models in place which are very appropriate to our country, rather than following models that are developed by NICE or any other models. So that's my only point. But I think we have a brilliant economic model, health economic model, whether it's Arvindai Hospital or LV Prasad hospitals in ophthalmology, and there are various areas where we do have example. We should celebrate vaccines and all those stuff where we have a lesson to learn. We need to capture it. So that's my broad point of view.
Thank you so much, Shank. Thank you so much, Vaidheesh. In fact, you have taken us through the evolution of the treatment options, health economics, and innovation. And I think it is appropriate that innovation has to be respected by not being much concern. And we also see the quality of perception in private versus public, particularly in India. Thank you so much. Omar, with your huge experience of domestic and international markets in pharma and now in medical device, would you like to share your views on health economics?
Yeah. Thank you, Vivek ji. First and foremost, a very, very happy new year to all of you all. Thanks to Dr. Anish for organizing this webinar, the entire team at Intellimed, and a great panel discussion that is happening with experts here. A huge thanks from my side. So, Vivek ji, from my side, I would say there's a lot of interest in the field of health economics and outcomes research, and it has only grown exponentially as governments and other payers, kind of grapple with how to provide the best possible health outcomes at affordable cost. We did hear Dr. Rajesh talking about it. It's a lot more evolved there in the US, but I believe that every healthcare decision should be informed by the best scientific research, which is derived from rigorous, proven methodologies, and Vaidheesh touched upon that. And toward that goal, our mission is to quite possibly promote the health economics and outcome research. And Dr. Katoch did say that we are doing well, and I believe that we are in the right direction. And we just need to make sure we improve the decision making for healthcare by bringing innovation to the forefront. And in doing so, in today's world, healthcare decision makers across the globe are often faced with the need to select the therapeutic interventions from multiple treatment options, including biopharmaceuticals, medical devices, like we are into diabetes care medical devices, and healthcare services as well. And I think what we tend to forget is if you take any of the therapeutic intervention, it has different stages to it, and those stages need to be built into the HEOR studies. However, the benefits and the costs of these interventions can range dramatically, and the benefits can be economical, the benefits can be clinical, or maybe also both, and may include hard measure costs or benefits to the patient's experiences directly. Let me give you an example from the area of diabetes, and we always say go by the rule of halves, which means in a country like India, 57% of the people out of the 77 million people suffering with diabetes do not know that they have diabetes. Out of this 57% people, only 50% of the people have access to care. Out of them, only 50% people are getting the right treatment modality. And out of them, only 50% are actually getting to the treatment goals specified by either ADA or IDF. So if we do our mathematics properly in India and likewise across the world, only 6 to 8% of the people are in good control of diabetes, which leaves us with a huge access to care issue, for that matter of fact, across the world. And in India, I think specifically health economics and outcomes research can help healthcare decision makers, including clinicians, governments, payers, health ministries, patients, and more to adequately compare and choose among the available options available in the marketplace. So I think this is what I would like to bring to the forum, and we can discuss a lot more, Vivekji, as we go through. Over to you.
Thank you so much, Omar. In fact, a lot of encouraging views on health economics, and I would appreciate your clarity of thought. And I think diabetes, you have been breathing in diabetes day in and day out. I totally agree that access to healthcare in general and access to medicine in particular in India is an issue, and I think all of us put together need to do something about it. Thank you so much, Manoj. With your exposure across pharma segments, across geographies, and now, of course, you are one of the important member of Executive Committee of OPPI. Would you like to give your thought process on health economics and health technology assessment?
No, thanks a lot, Vivek, for having me, and Dr. Anish. I think we always look at health as wealth, right? I think actually the wealth is health. So in that respect, wealth, when we look at from economics, we are looking at a net health gain through a health economic window, right? What are the resources we are putting in, and what is the benefit we are getting? Yeah, and I think what Omar and Vaidheesh said, I would take that discussion forward. I think a lot of time it's very easy for all of us to look at health economics or HEOR from a reimbursed market segment. Yeah, but actually health economics is also important for private play, and Omar did touch upon giving the example of diabetes patients, right? I think when you look at it in India, 70% expenses are out of pocket, and if the clinicians have visibility on the health economics of the treatment, and what I say is health economics, a major factor is data and science, right? We talk about evidence-based medicine. The clinical guidelines are based on that. Doctors look at those and are aware of it. Then the choice for him would be with innovative therapies. Are they better than a lower price therapy? Yeah. So then the focus is not only on the pricing, but on a composite value offering. I'll give you another example, Vivek, and which I study anemia a lot, out of curiosity. I do not have a product there. But India is a country where almost 50% of the population is suffering with iron deficiency or anemia. Yeah, the cost to GDP because of anemia is $22 billion. Yeah, it's massive. Are the drugs or therapies expensive for anemia? No, nothing. They are not expensive. Yeah. But if we apply the health economics or the HTA assessment, probably we understand the underlying reasons why the society is not taking it, why there is lesser awareness, what can be done to do interventions in clinical guidelines, in management of anemia, so that maternal health, where 20% is contributed directly through anemia, 50% is associated cause of maternal death, where India, I think Dr. Reddy started with that statistics, maternal health is death is very high. There is data to suggest, and why I'm saying it is so much related to economics, is anemic children, when they become adult, earn 2.5% less amount of money than their peers who are healthy. Yeah. So the anemia has a long-term impact on the society. So it's not just a loss for managing a disease, but it's a huge impact on the society, the caregivers, the stakeholders. And I think so the health economics has its fundamental for both the set of markets, a reimbursed market, but also out-of-pocket market, and then actually evaluating innovative therapy, is it better? And there is so much research happened where innovative drugs have actually lowered the cost of management of disease, because lesser hospitalization, lesser pain on the caregiver, lesser crowd at the hospital. So I think health technology assessment is an absolutely integral part, and we should probably go in that direction. I'm actually very, very happy and delighted to learn from Dr. Reddy as well as Dr. Katoch in terms of the progress which India is making.
Thank you so much, Manoj. In fact, I wanted to add, I think you have touched upon two important disease areas, diabetes and anemia. Let me share with you, OPPI did, we did a project for almost 3 years, and we did this project in Zawar, which is supposed to be the backward and the nominated tribe area. And OPPI treated almost around 7,000 patients for over 3 years period and provided free medication, the treatment, and diagnosis, etc. And in fact, I was going practically every month there, and we had zero mortality. No doubt we have improved on mortality, but I think I stand to agree with you that 50%, anemia cases cost around 22 billion is a huge, cost to the GDP. I think wonderful views. And you also talked about innovative therapy versus available therapy. I think with these thoughts, Anish, would you like to give your thoughts so that we can move on to the subsequent part? Anish, you are mute.
Yeah, thanks everybody for joining this session. In fact, one of the things which Vaidheesh also mentioned and which has been earlier mentioned by Dr. Reddy and Dr. Katoch is that I think we need to have our own data, we need to have our own studies, which are basically designed from our country point of view, because as Vaidheesh mentioned, we need not be relying on the data coming from a NICE or other things. Yes, that can be a good supplementary data. However, our conditions many times are unique, and as Manoj and Omar mentioned, we talk of diabetes. Diabetes is probably one of the important disease in our country. So the kind of data that we need to look at it and the paucity of data today available is many times creating that challenge. We know that from different data that when you control diabetes, when you bring it down and several measures that are used, we may be able to increase the kind of quality of life. Anemia is one of the very simplest example that was given. I work with Vaidheesh on a lot of surgical area. Now there is now a lot of data that needs to be looked at it from the kind of outcomes that we are looking at it today. Outcomes, as he mentioned very clearly, when minimally invasive surgery came in, it was clear that there was a very shrinkage of time in the hospital. You were able to perform your activities, get back to work very fast. So it was very evident. However, many times what happens, and if I look at and extrapolate it today, robotics has come into the picture. And then robotics, the cost of it is pretty high. So really, how do we really look at that from a cost to benefit perspective? What are the kind of data that we look at it? What are the kind of evidences that we needed to look at it from an Indian perspective? And considering, I think one of the issues which comes to everybody when we look at that India is a self-pay market, how do we really see the cost utility or the cost benefit advantages that are there when these incremental innovations come into the market? And again, they need to be having or changing patient outcomes. That's what is something which is very important. And from there, I think it's very important for us as an industry and as for from a different agencies needs to work together. So how do we really generate our own data? And we are able to get a benefit to the patient in terms of having that data and the kind of outcomes that our patients would get.
Thank you so much, Anish. I think very nice views from all of the panelists. I must appreciate the type of thought process which audience will definitely enjoy. Let me move to the second part of this discussion. DPCO 2013 is an implementation document for National Pharmaceutical Pricing Policy 2012 for NPPA. In fact, NPPA is expected to work on NPPP 2012, striking a balance between industry attractiveness and access to medicines in general. So with this in mind, Vaidheesh, would you like to share your thoughts, particularly on innovation in standard care and particularly with industry growth?
So, Vivek, as far as I'm concerned, I think enough has been said on this topic. But as far as I'm concerned, as a country, as a nation, we got to embrace innovation, and we should encourage innovation to come to our country. Every common man in our country should have an access to the innovation that will get them to live longer, rather than the technology is meant only for the rich people. It should be meant for everyone. Like the way I think COVID has done a fantastic job of COVID as a context where everyone is being seen equal, and that's how the healthcare should be delivered. One big difference that has happened here, which is what I would encourage, I'm quite sure the policymakers to look at, the integration of demand makes a huge difference to people who bring innovation. If I bring an innovation in oncology that's going to save, say, 2 million people who are suffering from the particular disease, people who are bringing innovation, they know that they will have an access to those 2 million, and they would be in a position to come up with a pricing that's of relevant for the 2 million people, correct? But if you don't give a commitment to people who are bringing those innovation, what might end up in having is it will become a suboptimal work for the people who brought the innovation. If I'm going to get only 10 patients at the end of the day who are going to buy at 200 rupees, and then I don't get the value of what I brought in as an innovation. And I'm just saying it broadly. So I somehow believe we have to get inspiration from some of the innovation that has happened in our own country. In the various technology area, I keep talking about Arvind Eye Hospital as a very good example of intraocular lens. I remember having sold intraocular lens in 1985 at 3,000 rupees. And the doc told me that is too expensive. You need to give it to me at 100 rupees, which I said I cannot, right? But the fact is that he created that whole platform, and he managed to create 3 lakh procedures that has been done, that he's able to drive the volumes and able to provide to a common man the kind of pricing that's required at $50, right? Entire cataract surgery. I think India is very unique. It's mass, volume. Only thing is that I would encourage policymakers to talk to those innovators, give them a commitment of volume, and get those prices so the innovation can go down to the common man. I think that's a simple principle. I'm quite sure that we all know the challenges, but I think we need to keep this as a basis of our conversation.
Thank you so much, Vaidheesh. Manoj, with basic thoughts from Vaidheesh about integration of demand, scaling up of operation, and pay for the innovation, would you like to indicate what need to be done with reference to pricing and balancing the innovation?
No, I think I completely agree to what Vaidheesh was saying. Yeah, I think pricing or access to medicine is an important topic. I think beyond doubt. But let me also give data on Europe, and I think this adds to further to what Vaidheesh was saying. You know, the cost of medicine in oncology for Europe, which is a reimbursed market, is hardly 1 to 2%. Yeah, so sometimes I think it's important for us to look at how is the value offering to the patients. Yeah, is impacted by offering a new therapy. Yeah, and we know the medicine is becoming personalized. If a patient who is at wheelchair to a patient who is not at wheelchair, injectable therapy would be night and day difference to them, because a person who can walk can go to the hospital, to a healthcare provider, take an injection, but somebody who is on a wheelchair would require a caregiver who along with that patient will go to a hospital to take that. Now if that is given an oral therapy which does not require injectables, it's a night and day difference for that patient. So I think personalized therapies, evaluating in terms of what is needed for that group of patients, innovative therapy, including in the HTA, so that the overall net health gain is being looked at. Even if the patient is self-paying, yeah, even if the patient is self-paying, is important to look at it and not just looking at the price of the drug. Yeah.
Wonderful, Manoj, wonderful. Omar, would you like to give your thought process based on all the work that currently Roche Diabetes is doing in this area?
Yeah, thank you very much for that question. I kind of agree with Manoj, and Manoj touched upon something which was talking about personalized, treatment, individualized treatment. And in diabetes, what kind of companies like us and many others have done is we have tried to deliver integrated personalized diabetes management solutions. And with COVID coming in, the mindset shift has happened with regards to both the healthcare professionals and also the patients. Today, as we see, as a result of the last 9 months, we see there is a lot more connectivity between the doctors and the patients, and the adherence to treatment has gone up the adherence to also monitoring themselves have gone up, and there's a lot of data sharing that is happening. So as a result of this, an integrated personalized diabetes management means that how can we let the patients take care of their condition in a way that they are empowered enough to do that on a day-to-day basis. And that can be done in many ways. For that, we need a lot of partnerships across the board, Vivekji, and there, because we pharma companies do not come with this technology mindset, so we might need to acquire these expertise with the third embrace it, and also bring it with in an integrated way to the marketplace, so that patient sitting at home does not now mind to kind of coordinate along with you, whether it be with the healthcare professionals, whether it be with the nurses or the payers, and across the value chain. So I think that minimization has to be in place some other way. But I just also wanted to bring forth, Vivekji, one aspect, because we've been talking about outcome research and health technology assessment. And I think in devices, this is very much required. And there are two related terms to this. One is the pharmacoeconomics, and the other one is the health technology assessment. So, and these two cannot be put together in the same bucket. Pharmacoeconomics is a branch of health economics, and which evaluates clinical and economic and humanistic aspects. And I think Dr. Rajesh put it very clearly in his 3E kind of evaluation. It provides a information to the healthcare decision makers. But the health technology assessment, on the other hand, is a process of critically assessing various properties of any medical technology. And I think this is used, and what it can do, like Manoj was saying, try to bring the aspect of individualized, personalized treatment as a part of these health technology assessments, because if data plays a very, very important role, then that HTA should take into consideration. Though all these things come with, both pharmacoeconomics and the HTA. While pharmacoeconomics is primarily concerned with the economic analysis of the pharma product, HTA has a wider coverage and includes any health technology, and the assessment includes economic as well as the other practical aspects of health technology in question. So my request would be that we also see, as innovation happens, we bring in the services that comes along with it. Vivekji.
Wonderful. In fact, hats off to your basic thought process. I must tell all the speakers and the audience that Omar's brainchild, integrated personalized database management, diabetes management, has in recent past achieved 3-4 awards, and I think that's a more than award. That's a contribution basically to the diabetic patient. As you indicated, almost around 80 million are suffering from diabetes. I think let me come to Anish. Anish, you are amongst very few people who know in this particular industry health economic outcome research and also the health technology assessment. In fact, what I told about 3 important emerging trends, that the real world data, the timely insight, and of course the clinical evidence. Would you like to share your thoughts and your experience with medtech industry to the audience?
Yeah, in fact, just before I start, I would just like to thank Vaidheesh, because he has requested that he would like to leave. So thank you, Vaidheesh, for your participation, and your insights are always enlightening, and I have learned so much from you. So thank you, Vaidheesh. Talking about this, I think from the medtech industry and from a pharma perspective, what I learned is that there are 2-3 aspects. Number one, it's basically and what Manoj said and what Omar said. One of the first important thing is education and awareness. So if you look at it, and the diabetes example, because Manoj knows it well, Omar knows it well, and I have worked in diabetes very extensively. So one of the most important things in diabetes is, if you look at it, and if you look at something as basic as insulin, insulin penetration at one point of time, if I remember rightly, the numbers was less than 1%. The pharma companies actually did extensive education with the physicians, with the patients. They undertook data generation and evidence generation activities and the dissemination activities of the data, which led to an increase in penetration. And I think both of you have probably have that, I don't have the numbers, but probably I had heard last that the insulin penetration had gone more than 4%, which is basically because of education and awareness. Now, when I look at it from my experience in medtech industry and the health economic outcome research or the health technology assessment, it's a long journey. Getting all these things, all the data together, getting the facts together, education, awareness is not a single day journey. So I worked along with Vaidheesh in the area of bariatric surgery. Probably around more than 12 years ago, Vaidheesh was the first person to get these kind of newer surgical procedures and techniques into the country. However, just to give you an example, in those days, bariatric surgery was considered as a cosmetic procedure. There was no reimbursement for it. There were not trained operators. So we had to work from converting bariatric surgery from the data perspective, from the evidence perspective, from the education perspective, first to bring it to all the stakeholders that obesity is a disease. It's not a cosmetic condition. So when we worked on it, we were able to convert obesity from a kind of a lifestyle condition to a disease condition. Once that happened, when we got this recognition, when we generated the data, we were able to work with the insurance companies, we were able to work with different stakeholders to identify that as a disease, to identify a procedure that can help. That evidence helped us to get reimbursement not only from CGHS but from different other companies or from other insurance companies. So that's a kind of a thing that you need to. It's a long haul, and that's where when I talk to it, I think it's the under the domain of CEOs and the country heads to really drive that part of it, because it's much beyond a commercial leaders domain, because it's a strategic vision that you need to look at it. We again worked on certain sutures. We had our innovative sutures coming in, incremental innovations was there. So how do we really position that at that point of time? So we again went on is that we had to generate the evidence. And it took a long time. So first I had to generate the evidence. Then when I had to work with companies so that I could and work with the stakeholders, government or public or private hospitals to generate that evidence and put it in a document to show that how a small incremental cost can help you to prevent certain surgical site infections and have a cost saving of nearly 8 to 10%. So these are the kind of things. So it's a long journey. We need to invest time and money and address the right stakeholders with the right data. So that's where I think it's very important from a health economic or an outcome research or a health technology perspective. And again, one thing which Vaidheesh very clearly mentioned is that we need to have the right data from our country point of view. So these are very important things which we as industry leaders need to recognize.
I think very nice views. In fact, you have strengthened what I talked in the initial stage, that the data and the insight and the evidence. In fact, I must tell you that Omar has contributed in a big way. Many will know that Mixtard is even today #1 product of the industry, and his shadow is even working today, who has developed Mixtard in the past. And in fact, Manoj has also said about the diabetes. With this, Omar, I would like to come to you. Would you like to have some specific recommendation for the effective implementation from the government side as well as from the industry? Because investment in this outcome research has to be there. Evidence-based management will be the future. Would you like to share your views on this?
Yeah, I definitely would like to. And I like to reiterate what Dr. Katoch did mention, that, when we get into this, we need to be really, really honest about it, and not have a hungry appetite of only commercial aspect of it. I think that is true to any therapeutic area. And sometimes we as pharmaceutical companies do not take, Vivekji, the aspect of prevention. I think we need to move that ladder and say, okay, we will walk that path of even the prevention, even if it doesn't get us any business in the future. So I think first, Dr. Katoch's point is very important. We need to be as an honest industry partner to get into this area. And there, we need to enhance understanding of the economic behavior and the patterns around it. We have seen a few models from Dr. Rajesh. We need to see how, with the help of PHFI or certain other institutes, deliver white papers, state government by government, to make sure there is a burning platform for any NCD or any therapeutic area. We need to provide valuable input to the health policy and health services and try to create a guideline for a particular therapeutic category, whether that be intervention at an early stage, at a mid stage, or at an intensive stage? And what is the cost or a control budget versus the price allocation that we are looking at? The next, I would say, we would also like to improve efficiency and the equity management, like what Dr. Rajesh was mentioning. Very, very important, because screening is one part of it. And for example, if you look at Maharashtra, companies like us can come forward and say we can screen 2.5 million people with diabetes in the state. But there is a larger population out there, so it has to be scaled up over a period of time. So that scalability has to come in. We need to also influence emerging issues in the pharmacoeconomics that I was trying to mention, and also try to build the health technology assessment of devices and therapies to make sure there is a little bit evidence-based, value-based, and also patient-centric approach to outcomes rather than anything else. That is what I would say, Vivekji.
I think wonderful. In fact, you have brought a new dimension to this panel discussion, looking from the 360-degree, stakeholders' point of view. You have given a new dimension like public-private partnership for this particular area. Wonderful. Manoj, would you like to share your thoughts on this effective implementation?
No, I think Omar has actually shared almost everything. And I'll also go back to what Dr. Katoch said, right? I think there are health economics models where country has really progressed well, both at the research level, but also in pockets where the tools have been applied. I think what we need to look at it, how do we have a uniform implementation across the boards, right? And I think that to me is great, and I think we have all the foundations to do that, and I think we are very well placed for that. So my outlook would be all the stakeholders who want to put patients at the center of whatever we do, and pharma companies, including like ours, the early we can adopt it in a uniform manner across the board, keeping innovative therapies equally towards that, and also listening to what patients want. Yeah, I think we are. From here we can only grow in strength by using health economics in improving health parameters for India.
Thank you so much, Manoj. Uh, Anish, let me come back to you with the basic thoughts, given by Omar on public-private partnership, and Manoj talking about the investment from the organization for this great cause. What is your take on this?
So I think Omar very nicely mentioned it, that we need to work with all the stakeholders. In fact, one of the most important stakeholders, which we all know, is the government. And what happens is that there are a lot of documents which are being the government is working on. So if in some way we are able to have a kind of a collaborative approach in working on these documents, because I remember when the orthopedic implant pricing came in, there was a document which was worked on by the government. So, however, if if the industry can be a part of these, and we can create that ecosystem wherein we are able to work with the stakeholders in terms of the patient outcomes and generate that kind of documents or those kind of white papers, which will help us in getting innovative therapies to our patients, that would be the right approach, in my opinion.
Wonderful. In fact, let me share. I've been working in this area of DPCO and NPPA, particularly the stent and this, the implant, implant, and the this orthopedic implant. First, they were not drugs. So what NPPA did, they invoked para 19, and in order to bring them under price control, in fact, they slightly drifted away from national pharmaceutical pricing policy, and they, of course, initiated a statistic study which need to be studied. And I think that could be a lesson for the device companies to be ahead of time and find out for their devices if such thing happen. There could be a proper risk minimization and at the same time contributing to the great cause of disease prevention. Wonderful. I think for want of time, let me come to the last part. I'm sure audience would be keen to have a key message from each one of you. So shall I start with Manoj? Manoj, what would be a key message on this topic? Maybe quickly in 1 or 2 lines.
I think I think everybody can increase awareness around this topic. Uniformity of applying tools. I think tools are already there, so there is no. Yeah. And the last thing is in India, I think data generation is critical to look at the data and, as we say in clinical trials, evidence-based, but also health economics data to put clinical guidelines even for private play. Yeah, I think reimbursed market is still smaller in India. The private play, the health economics can really benefit. Yeah.
Thank you so much. Omar, your views on this before I go to Anish and wind up?
I have three things to add here very quickly. One from the pharma industry point of view, and third from the patient's perspective. So let's take the first one, the payers. I think the committees must become more sophisticated in considering the quality of the HEOR data being presented and use it appropriately. The second, from a perspective, as I told you earlier, we need to get into partnerships with the government to ensure there is a little bit more broader than the commercial approach to support the cause of the government. And from a patient's perspective, Vivekji, I would say we also should have a partnership here to critically evaluate to the best of their ability in terms of patients' understanding of the data, because they should also understand, they should also be a part of this and go to their trusted healthcare providers to help them interpret the evidence.
Wonderful. Anish, would you like to quickly give your thoughts?
Yeah.
As a message?
Yeah, so what I would like to say is that we need to work with different stakeholders in a collaborative manner for awareness, which is there, and the data generation, which is there, which can then lead to better patient outcomes and acceptance of innovative therapies for a larger good of the country. So that's what I would like to say.
So thank you so much. I think once again, I thank all panelists, Vaidheesh, Manoj, Omar, and Anish. Thank you so much for your contribution. I also thank audience for sparing their valuable time for this unique webinar. I think this is one of its sort. A lot of other webinars have occurred, but in this area, this is the important webinar. I think Dr. Katoch and Dr. Srinath Reddy have really set the ball rolling and added more value also by Dr. Balkrishnan. With this, let me hand it over to Dipti to take it forward. Thank you so much once again, everybody.
Thank you, Mr. Vivek. It has been a very enriching session on HEOR, and I would like to thank the audience who were the first motivators to show keen interest, and it has been our motivation to put it all together for them. I thank our speakers, Professor K. Srinath Reddy, Dr. V.M. Katoch, Dr. Rajesh, Balkrishnan, Mr. A. Vaidheesh, Mr. Manoj Saxena, Mr. Omar Sherief, Mohammad, Dr. Anish Desai, and Mr. Vivek Padgaonkar. Our academic partners, IMPA, that is Indian Medical Pharmacologists Association, our expert partners, Alpha MD, our media partners, Pharma Shots, and our own team, IntelliMed, who worked relentlessly to make this possible. So thank you very much. Stay safe and good night, everyone.
Thank you so much. Thank you so much once again. Bye-bye.
Thank you.
Thanks.